going to cover about the definition, the practical aspects of the definition of diabetes, types, the diagnostic criteria that is available there in the international standards, and what is applicable in the context of Bhutan, the drug classes that are available in Bhutan and in your center, then how we set targets for the treatment, how we titrate medication, and then how to identify the chronic complication. And with the overall aim that you are able to manage diabetes of the medication and you are able to achieve good control. Diabetes now the primary problem with diabetes is that it is a growing. The reason it's growing is because in our community we have plenty of risk factors of diabetes or NCDs. The use of tobacco is going up. There's many people who use DOMA, and it will be a very good research topic if anyone of you would like to take a study on the prevalence of DOMA use among the community or health workers. It's a very simple topic. There's increasing use of harmful use of alcohol. When we're looking at the diet, majority of us do not meet the requirements for a healthy diet. A very poor level of physical activity, and in terms of your metabolic risk factors or the biochemical risk factors, this is as per the last step survey. The proportion of people with raised blood glucose is 1.9, but I heard that with the recent national health survey, the proportion has gone up. Almost 1/3 of our population has raised blood pressure, and 1/3 has obesity, and then 11% has raised blood cholesterol. Now, all these factors combined together gives you a very good. It's a very good environment for you to get diabetes. Now, these are the very specific risk factors for diabetes. This is just a recall. Now, diabetes, everyone has learned about diabetes in the definition, biochemical definition of a diabetes in your undergraduate school, where it is a state where you are unable to metabolize carbohydrate appropriately, and it results in hyperglycemia. Now, this hyperglycemia is causing you the problems from head to toe. This is the theoretical definition. Now, in terms of classification, there are types 1, type 2. Type 1 is where there's this destruction of the beta cell or the beta cell destruction, and that's why there's insulin deficiency. In type 2, there's some loss of beta cell function, the insulin is not working, so there's a combination here. But in type 2, you don't begin with the insulin deficiency. Now, there are many other group where you get diabetes because of you have genetically you're unable to metabolize, or there are some receptor abnormalities. No, these are your genetic predisposition for diabetes. And there are secondary causes like a person where you have a lot of steroid use, or because of secondary causes such as those with pancreatitis or cystic fibrosis. Now, in Bhutan, as of now, we have very few or almost none, 0% people who are diagnosed with other types of type 3 diabetes, mainly because right at this point of time, we do not have the capability to diagnose. And then the other category is gestational diabetes. Now, gestational diabetes, it's a very different set, and the diagnostic criteria is different. Now, clinically, there are different types of diabetes, but these are just theoretical description. Now, when it comes to type 1, type 2, when it comes to type 2 is the one usually you have this osmotic symptoms of polyphagia, polydipsia, and weight loss. Now, when we go to for the diagnostic criteria, now comes to our practical application. As per the international AD, American criteria, these are the types of tests that we can utilize for making the diagnosis of diabetes. The first one is fasting blood glucose, prostaglandin 75 OGTT, 75 gram oral glucose in Jinbe, OGTT, HbA1c, and random blood glucose. Now, there are very specific conditions in which way we can adopt this from the 5. There are very specific requirement for you, whether it's valid, whether you can adopt with validity. Now, first one is fasting plasma glucose. Now, it's where for fasting, it means that there is no calorie intake for at least 8 hours. It means that you're allowed to take water, but it comes with a very different catch, because our patients might mistake this, and then they might take some other content such as juice or tea that has any calorie in it. So it's always better to have, I mean, better not to say that, better to say that no, you're not allowed to take everything. That's just to avoid miscommunication. But technically, you are allowed to take water because it does not contain calorie. Second one is you can use 2-hour plasma glucose with the threshold of 200 or you use oral OGTT. In OGTT, you take 75 grams of anhydrous glucose and then dissolve in water and then measure it after 2 hours. Now, for fasting and post-prandial plasma glucose, the cutoff is 126-200. Now, this is very easy to remember and easy to do in our setting. You can also use random plasma glucose, but this has to be interpreted in the context that patient has clinically any symptoms of hyperglycemia, or somebody who has come with hyperglycemic crisis such as TK or HHS. Now, the next part is that HbA1c can be used for diagnosis if the method of testing is certified by NGSPK, National Glycosylation Standardization Protocol, Project Kiwi, if it is if your method is certified by this. Now, as of today, I checked in JD and both in CRRH, the method that we use is not NGSP certified. So if you look into the leaflet of how we test our HbA1c, it says that you calculate HbA1c, and if you want to really find out whether whatever HbA1c is measured by the Ningmachi hospital, whether it really correlates with NGSP certified method, there's a mathematical formula with which you can make a conversion and try to get a NGSP certified value. But your primary method is not NGSP certified. Therefore, for diagnosis, you can use only fasting PP and random plasma glucose if you have used it in the right clinical context. Now, for confirming diagnosis, you need two abnormal readings. Both fasting and PP should be abnormal, and in at least 2 different occasions. Now, what if you are only if your fasting plasma is normal, but then your is normal, but only your BP is slightly raised, but does not meet the diabetes criteria? Here you will call it as impaired glucose tolerance. And if your PP is normal, if your fasting is abnormal, then slightly raised but not meeting the diabetes criteria, you'll call it impaired fasting glucose. So these two are two different entities. You do not start treatment in these conditions, but you follow it up more frequently, because it is likely that with lifestyle modification, dietary modification, some of them might get back to normal, but majority of them usually progress into diabetes. So you have to follow them up so that as soon as they move into diabetes, you are able to diagnose them early on time. Now, so far is I have considered covered only the basic components where everyone knows. Now comes as a doctor level, at a doctor, as a doctor in a primary healthcare center or in a general hospital or in a regular hospital. When the patient has first diagnosis of diabetes, what are the components of comprehensive evaluation? Very simple: history taking examination and look for organ complication. Now, for history, we would like to look at onset, how soon, how young, or now sometimes patients come to you with a diagnosis of diabetes, but when you look into history, you will find that he has already been diagnosed. Somebody else has already diagnosed him as diabetes for past 2 or 3 years, and he has not taken medication. Now, it means that this is again, you are making a diagnosis, but this the likelihood of having organ complication is more. So you have to look into very specific things. Now, family history, you should look into first degree relative, because why? Because this is more likely to be type 1. Then you look into other risk factors such as obesity, hypertension, because these are more likely to have in these patients, you are more likely to have a complication with diabetes. Now, you look at the behavioral factors. Why? Because now in SCCI also, you are trying to make a very specific targeted intervention. Now, when you make intervention, your target has to be patient specific. So you look at the eating pattern. If somebody is already having a good habit, you just reinforce, but somebody not with a very bad poor habit, you try to improve on them. So from these, now in behavioral factor, now if somebody is both a smoker and alcohol consumer, no, it's based on history, and you can prioritize and see intervene one at a time, or if it's possible, both. But taking history is very important because you want to be more successful. So maybe you can adopt one at a time. The current medication is all medical history, and current medication is important because you would like to see the specific conditions and see the indications and contraindications of certain medication. If you have any questions, let me know in any time. Now the ETA also says that you should need to know family support and social support is important because many of our patients with insulin, especially on insulin, their insulin is being administered by family members. So you need to know them. Now the use of technology is also important, the literacy, because in many countries they are now going towards health apps or self-monitoring of blood glucose, self-recording and self-evaluation. In physical examination, same, nothing new, no height, weight, BMI. If you're able to do fundoscopy, go ahead. You should also look for an acanthosis, dark skin with dark, greasy, shiny skin over the neck or around at the intertrigo. Now, this is important because this represents that the duration of your insulin resistance. You should examine the foot because patient will have any diabetic foot. For laboratory evaluation, now this is important because in SSCI, I hope that many of you have undergone the look are aware of the SSCI diabetes-based and protocol-based management. There it says in the first step, the HA will diagnose, and at certain point of time, within first 3 months of diagnosis of diabetes, this will come to a doctor. That can be a doctor in the secondary level or a primary level. So when the patient comes to, what do you need to do? So you need to look at HbA1c lipid profile and the organ impairment, RFT. Urine, if you have urine protein creatinine ratio, it's available in Thimphu and Mongar, not even available in Gelipu. But in others, you can do urine protein. Now in the now we come to the management of diabetes. Now diabetes management, Nalu, in undergraduate, if anyone asks you about how will you manage diabetes, you will always answer you will manage with pharmacological and non-pharmacological management. Now pharmacological, but the basic principle here is that now it is highly encouraged that patients should be involved in making the making management plans about how to manage the diabetes. So self engagement of patients is very important, right? And you will encourage self-management. Self-management will include them knowing about when to do the next test, what medication to take on what time, what to monitor. They should be monitoring about their food, eyes, when to monitor. So it's as much as the health workers would like to take responsibility of the patient, now it is encouraged that you should share this encouragement with the patient family members. Okay, now next is first when we are making the lifestyle intervention, first comes your nutrition. Now in nutrition, in the context of Bhutan, we have to take consider and understand that it's very difficult to have any accessibility of food and variety of food. So you should understand the socioeconomic condition of the patient. In this case, it's very difficult for us to say don't eat this, don't eat that. So now in SSAI, we encourage people, your advice should be that you should say take heart healthy diet. In heart healthy diet, and Nalu, your objective should be, it should be in moderate quantity, maximum variety, and and then it should also be linked with how much weight gain you are having. Are you targeting weight loss, or what percentage weight loss are you actually targeting? Now in carbohydrates, Nalu, you should encourage those that are nutrient dense, and then those with lower glycemic index in any food. That is one advice that you can give. Protein, uh, we'll go to the next one. Carbohydrate D, in one meal, you should be encouraging 6 to 11 servings, but preferably low glycemic. Low glycemic index food are those that has some fiber in it. So white rice, the red rice, whether which one is better? The one that has fiber in it. Vegetable. Then you should encourage vegetables 3 to 4 servings. Fruits, dairy milk products 2 to 3 servings. Meat, kinalu, it's usually red meat, which has less fat in it, subcutaneous fat less seeming, 2 to 3 servings. Now, how do you advise on fats and oil? Oil, you tell them to use sparingly or less than two spoons per day. that's 2, and salt kinalu 1 teaspoon for all your 3 meals. Now, as we have more people with education, with literacy, we should encourage them to be literate about reading food labels. Food labels will give you a clear description about how much calorie it has and how much added salt people can know about it. So you always encourage them to read the food labels. Physical activity, 150 minutes and but basically you need to tell them about adoption of physical activity and being consistent on it, and that they can manage their timing so that they can do 30 minutes for 5 days a week. It's not necessary that they should be doing it. I mean, it's not compulsory for them to do it every day or do uh, at a very gym not do those things that would require additional effort. We should make them as to make it physical activity adoption. We should make it as easy for them as possible to be done within their own setting. Now coming to glycemic target. See, physical activity, diet, and now coming glycemic target. Why am I introducing glycemic target before the medication? Is because it at a certain point of time, after a certain level of high glycemic level, it becomes impossible for you to control with food and exercise. So here, HbA1c, the HbA1c that we have in our hospital can be used. So HbA1c less than 7. Fasting 80 to 130. So your target should be fasting 80 to 130. Postprandial less than 108. Now, if you are so afraid about getting hypoglycemia with this target, then you can give a bonus or give up additional gap of around 20. So you can go up to 180 and 150 in fasting, and postprandial maybe up to 200. Now here there comes a balance between two things. Either you give a lot of gongyang, no? You give a lot of leeway for patients to have a higher glucose, and you consider them as glucose because you're fearing hypoglycemia, or are you actually not treating the patient up to the standard recommendation? So you have to make a balance. Now, when you're making this target, you have to monitor it and balance it with your monitoring. Now, monitoring in many of our hospitals, including some of the primary healthcare centers where doctors are there, we are able to do venous blood glucose. Now, if it is feasible for you, the best recommended one is venous blood glucose. However, if you do not have any facility to do venous blood glucose, you can do capillary blood glucose, but that is recommended only if you do not have any other alternative, to measure your glucose, to monitor your glucose. You can use with HbA1c, and now there is continuous glucose monitoring where you put a probe on the skin, and then that I think that it reads your glucose, and then it gives you 24 hours glucose reading. So CGM is coming in a very big way because it really gives you your response to sugar intake. For example, after you take a meal, how much your sugar rises. After you take your medicine, how much is able to control, or in the morning dip, whether there's a dip. So it has a lot of with continuous glucose monitoring, you will be able to better manipulate your doses and control them. But so far in Bhutan, we have not used CGM, but I think this is something that might come in the near future. Now, when the patient comes to you, you have a lot of information. You have taken the history, you have examined, you have looked at the target organ damage, and the patient is already reinforced, or patient already knows what is dietary intervention, lifestyle and modification that you already knows. So you have a lot of information based in your hand to decide which things to be given. Now, for pharmacologic approaches, okay, this is in general what is available in the market. So biconite there's metformin, Ecarpos, Voglibos, Bhutan it's not there, but those patients who get their medications the revised in India, they come with Ecarpos. GPP4, we have GPP4 inhibitor. The only choice that we have is vildagliptin here, and there is sulfonylurea group. We only have glipizide. From SGLT2 inhibitor, based on the National Essential Medicine List of 2023, we have dapagliflozin that is available only at GDW NRH. So for now, they are going to assess how dapagliflozin is being used, how much it contributes to sugar control, and then subsequently, in coming years, if the use is good or if there's this any requirement, they might roll it down. But for introduction, it's a big step that it has already come into Bhutan. For thiazolidine pioglitazone is there, and from parental agents we have the short-acting insulin, but that is not to be that's never been in OD. Now, what is there in our EML is mixed start 70-30, 70% NPH and 30% regular. Now, this is the variety that we have. Now comes, this is from the essential medicine list. When you look into it, you have at the primary healthcare center, you only have metformin. So that is why HA will start on metformin and send it to you. When you send the patient back to primary healthcare center, patient might go with any of these drugs, which means there's a mechanism through Form 3 and through SSCI with your registration and everything. The patient is supposed to get all the medications in his primary healthcare center, but that is now comes HA Giladi to get the medication from the nearest hospital. Now, as a doctor in the hospital, you should know how to which one to add, how to add, how to do up and down, how to titrate. These are the oral agents. Now, dapagliflozin comes as 10 mg tablet, and in Gelifu we don't get dapagliflozin through the hospital, but there are many patients who are willing to buy them from they have been actually they were put on dapagliflozin long before dapa came into our essential medicine list for past 1 or 2 years. Now, next is insulin didakhale. We have at the primary healthcare level, there's no insulin is available through that list. But if you prescribe, then they can get it through. And the easiest one is to titrate the doses mixed start. Okay, now coming to how to add or up and down your medication. Now, this is from Harrison's patient with type 2 diabetes. So you will individualize glycemic target. Glycemic target D we have already mentioned. First line of intervention is nutrition therapy, physical activity, weight loss. This has to go to each and every patient, irrespective of whatever condition. Then, unless there are contraindications, every patient is better to be on metformin. There are many reasons. We'll discuss it in subsequent slides. So the first starting point is nutrition, lifestyle modifications, alcohol brief intervention, everything plus metformin. So metformin, there's no need to say anything about it. So metformin must be there. Then, based on your target, this is American standard. They are saying GSS HbA1c. Here we will be doing based on fasting and PP. And after this, then you will have a combination of therapy. Now, what are you going to add? And this will discuss in the subsequent slide. You can have a combination of only oral agent, metformin plus other oral agent, or metformin plus insulin, or some these patients are only on insulin. But we can discuss on the merits. Now here, if a patient is with disease or any renal impairment or diabetic kidney disease, better is to have SGLT2 inhibitor, which means dapagliflozin that way, or liraglutide, semaglutide, and GLP-1 inhibitor. Somebody with heart failure, SGLT2 inhibitor has been shown to be benefit. High risk of atherosclerotic CVD risk GLP-1 receptor antibody. Now, and then you will make your decision based on the side effect profile. And for insulin therapy, there are so many factors that you need to consider, but you should not be afraid about it. Wherever required, you should go and prescribe. Now, this is from EDA 2021. See, the earlier slide and this slide, though crowded, talks about the same thing. When you begin your diabetes management, the first line therapy is metformin plus your lifestyle modification. So there's no question about whether the patient should be on metformin or not. So patient should be on metformin unless there are contraindications. Now, there are contraindications are very few. Now you look at the patient profile. Now, if a patient is having high risk of atherosclerotic CVD and atherosclerotic cardiovascular disease, high risk such as the coronary heart disease or peripheral artery disease, here your choice is SGLT2 inhibitor. Somebody with you should, which means metformin plus SGLT2 inhibitor. If the patient is on heart failure with ejection fraction, initially they started with heart failure with reduced ejection fraction, less than 40. Now they have increased the threshold up to moderately reduced MR, moderately reduced ejection HRMREF, which means up to less than 50 nalua you can give. Somebody with heart failure, you will next agent to be added after metformin should be SGLT2. Somebody on CKD or diabetes kidney disease, you will add SGLT2 inhibitor. Now, what are we doing here in Bhutan? After metformin, what are the choices that we have? The choices that we have is pioglitazone or glipizide. So we are adding pioglitazone or glipizide here, thiazolidinedione or glipizide. Now, as per standard, what does it mean? Standard it says that you give glipizide or pioglitazone only if cost is an issue, say so in other countries there are the way they add on to medication is different, but you should understand the logic behind. Now coming to which oral agent is better. So you look at the HbA1c reduction. So metformin bigonides, when you are using metformin in a good dose, the HbA1c reduction is 1 to 2%. But when you look into others also, vildagliptin, it is reduced to 0.5 to 0.8. Sulfonylurea 1 to 2. Okay? And thiazolidinedione 0.5 to 1.4. Overall, insulin also, all the agents are actually having similar, not limited, but similar amount of HbA1c reduction. Now, which one is actually having the highest the impact on HbA1c? It is actually your diet and physical activity. So if you combine, you will have an additive impact. That's why all the guidelines, including SCCI, says that you should implement the lifestyle modification first and then go on to drugs. When you really look into these numbers, personally, I don't feel that any one of the agents has a very dramatic so that's why even though the list of medications that we have in our hospitals is limited, when you really look into the evidence, I think it is fairly okay for now. And contraindications will adverse effects and contraindications will discuss individually. Now, why do we need metformin? Metformin is widely used in our setting. We usually start at 500 twice a day. Minimal risk of hypoglycemia. So if a patient is on glipizide and metformin and patient goes into hypoglycemia, it is unlikely that metformin is the one that is causing hypoglycemia, which means that if you want to reduce the dose, you should be intervening on glipizide, not on metformin. So you start at 500 BD and you can go up to 1 gram 3 times a day. So in some countries, people are afraid, and then they say that metformin maximum is 2 grams in a day. But here, metformin has hardly any side effects. You can go up to 3 grams a day in total. GI side effects are dose dependent, which means we have many patients who will say that, oh, they feel bloating, abdominal distension, diarrhea. Now, in Bhutan, people have this misconception that if one says that, oh, I had this abdominal distension, another one will say. So it's very difficult to really ascertain whether the side effect was really due to metformin. So if you want to avoid problem, the best thing is to start on low dose and keep on increasing the dose. Now here only you will not start GFR metformin if GFR is less than 45 kOA. If it's starting to fall less than 45, you not start. But if somebody has been on metformin for a very long time and then GFR starts to fall down, you can continue until it falls to less than 30. And when a person is very severely ill, fever, hospitalized, unable to take orally, you will hold metformin for a while. Now, The takeaway point from this is that as per the standard guideline, including protocol-based management for SCCI, patient should, any person with diabetes, including type 1 diabetes, they should be on metformin. Why? Because it is insulin sensitizer and it has many other benefits. That's why now if a prescription is missing of diabetes and metformin, you should ask the patient, no, why has it been stopped for any reason related to side effects? Then you can actually if it was missed just because somebody didn't think about it, it's better to put the patient on metformin. And when you look into in your OPD, there will be many patients who would have benefited from metformin, but but on you in this scenario you can you can ask the patient, and if it was not stopped because of a side effect, you can patient should be on metformin. This is the takeaway message. Now next comes your pioglitazone. Pioglitazone you can start at 15 milligram OD and then you can go up to 30 milligram OD. Here it has other advantages. It is also it improves insulin sensitivity, and it does redistribution of fat, and it has advantages. Now only side effect is some might complain about the ankle edema and swelling. Now a person on the diabetes having ankle edema and on pioglitazone, if the person has ankle swelling, you should think about pioglitazone, but you should also think about, is it has already gone into CKD? Is it because of heart failure? Is it because of fluid overload? So you have to rule out other causes. So in such scenario, you cannot make a direct association that pioglitazone has caused swelling. So you have to think, take a step back and evaluate everything. And if you have ruled out everything, then you can say that it is because of pioglitazone. Now comes glipizide. Now glipizide is actually considered to be one of the safe drugs. There's no, I think, there's no literature or no experience from others saying that no, it is a very bad drug and then you should not start, because sometimes you are so afraid about hypoglycemia. Now it's very safe. Provide the advice that you should give is that you eat with the first major meal, and then you always try to start at low dose and increase at 1 to 2 week interval slowly. The issue is that sometimes when you are young, when the sugar is 300, sometimes you're so you want the sugar to be 120 in the next 1 or 2 weeks. Now sometimes we have to slow down ourselves and then get the sugar under control slowly, so that you will be able to titrate. Okay, first you give glipizide 2.5 or 5, and then you see in 1 to 2 weeks, so that whether the dose that is the sugar under control. Now, in such cases, you have to tell the patients that for the first, until your sugar is under control with glipizide, you tell them that you'll have to come to the hospital. For next 2 months, you might have to come frequently, but after that, you can come monthly or 2 monthly when everything is under control. So long-term use has a lot of advantages. Risk of hypoglycemia is there in older adults, not because of medication itself, because sometimes in old elderly, you have to take into account whether they are getting adequate meal. There are so many reasons why elders don't take meal. Self-help, you're unable to cook, you're any frailties. There are so many reasons why in geriatrics people are unable to take meals despite them being not any physically or any illness merely. So that can be one of the reasons. But in such cases, you have to titrate your dose. Now, those with severe renal and hepatic dysfunction, because it's renal excretion bindigi, this can cause hypoglycemia. So sometimes if a patient who has been on glipizide, 10 milligram BD for a long time, and now suddenly comes without any illness, suddenly comes with hypoglycemia, and hypoglycemia, so same dose is causing hypoglycemia, it might mean that your patient is going into chronic kidney disease, and then the renal function is going down. That can be one of the reasons. So it means you have to check the renal function and then go toward the evaluation of CKD. Glipizide, you start at very low dose, maximum dose is 20 milligram BD. Okay, if you have any questions, you can ask me. Okay, now comes vildagliptin. Now, vildagliptin, the DPP4 inhibitor, you will start the maximum dose is 100 milligram. Now you can give as OD, but you can start as 50 milligram OD and then take it up to 100 milligram OD. Now, vildagliptin per se, this is it renal safe in CKD? Not actually proven. Now, there are many other types of gliptins that are actually indicated for CKD, but unfortunately in Bhutan we don't have any choice but to give vildagliptin. So in CKD also, though there's no any clear evidence, we are giving and then we have not faced any problems. Now comes dapagliflozin. So dapagliflozin, you will start as 5 milligram OD, or you can take up to 10 milligram OD. It is a diuretic actually. No? So proximal convoluted tribunal inhibit the reabsorption of the glucose and sodium. Here it induces loss of weight and it will cause BP reduction. So which means that if you are expecting that dapagliflozin is going to bring down the BP by this, it means that you tell the patient that, okay, no, you might feel lightheaded. Or if the patient is with hypertension medication, you can consider reducing the dose of other antihypertensive agents. So you need to take everything into account. Heart failure and CKD, those with heart failure and CKD, it has very good evidence. In heart failure, it reduces the mortality and hospitalization. In CKD, the advantage of dapagliflozin is that it slows the decline of your creatinine, renal function. It means that somebody with CKD, to slow down it's a very big achievement. Adverse effects, it causes slight increase in UTI and euglycemic diabetic ketoacidosis, where you have patient has ketoacidosis, but sugar is less than 250. Now, are these side effects a major problem in the clinic when you have started dapagliflozin on many patients? Is it a major problem now? No. These are adverse effects that can occur, but have I seen in my patients? Very few. So it's fairly safe. No, you don't have to worry, but you can give. Now comes the main question about Mixtard or insulin. Now, what is the insulin that we have in our hospital? Now, that oral agents, where every patient follow-up on the loop, and you are looking at your SCCI targets. If the patient is unable to reach the target, then you will keep on adding the other agents. But at the same time, you will reinforce lifestyle modification, dietary modification, and you will ensure compliance. And then that's how you will titrate your medication. Now, there will come a time where you might have to use Mixtard or insulin. Now, insulin, the Mixtard kiri, it's 70-80, which means there's this intermediate acting and short acting. So the intermediate acting and short acting is the one that is bolus, that will help you counter the post-parental glycemic rise. Now, Annaluri, one of the major side effects of insulin is it might cause hypoglycemia. So in that case, you will have to tell the patient that you should at least have a consistent dietary pattern. Now, who requires insulin? It means insulin, the patient has good dietary control, doing exercise, and then all your oral medications are now approaching maximal dose. In that case, this one scenario where you will be using you will have to think about insulin, which means that you will have to prep your patient. No, this month sugar is 300, and then the medications are almost reaching the maximum dose. Okay, you see, tell your patient that this month, by this month, your medications are on full dose oral medications. Now, if in the next month, if you are unable to control, then you might have to use insulin. So this means that if you keep on prepping your patients, telling them appropriate information, it is likely that the uptake of insulin will be easier, because at some point with everything maximal dose and the sugar is still 40, there's no other option that you must initiate the patient is not ready, but it does not serve the purpose. So you should tell and you give adequate pre-information. Now, in terms of HbA1c control null, so in US and where there are facilities, you add diagnosis of diabetes, they do HbA1c, and then they check if the HbA1c is more than 10. It means that at that point, especially initiate Biodolo, you will require your insulin in conditions where HbA1c is more than 10. Now, why do you need this? This is because when there's very high level of glycemia, there's something called as glucotoxicity, which means when the sugar is very high, your insulin does not work. No, whatever insulin that is there does not work. So to break that glucotoxicity, you might require insulin. But in such scenarios, see, there's these two scenarios. The patient with oral agent, and then things are not working, then you add insulin as a top up. In this scenario, there's this newly diagnosed, the sugar is, I think, is very high, not on any medication, and then you are starting both insulin and you are giving uh, insulin and oral agent. In this case, is in the second case, you are trying to break the glucotoxicity. In such patients, what happens is that you might the requirement of insulin over the subsequent months will go down, and if within first few months the sugar will come under control, and in such cases you will have to bring down your glucose lowering agent. Now, which one to bring down and stop? It will be best that you bring down the insulin. I hope I'm not confusing you. So initial dose should be titrated once or twice weekly. Once weekly, which means this is very important. After you are starting insulin, when are you expecting your sugar to come under control? This means that if you start insulin today, your sugar will not come under control tomorrow. So this message is important because you get consultations from the surgery ward saying that, oh, sugar is not under control, and then I go and titrate the insulin for today, and then they have given the insulin for tomorrow, and then tomorrow evening they'll give you a call again saying, okay, the sugar is not under control. No, for insulin, when you're titrating insulin, your sugar control will come only minimum after 3 to 4 days, which means the retitrate version after 3 to 4 days. So in such cases, I don't I tell the surgery ward nurses, no need to check sugar for next couple of days. You check it after 3 days. So only after 3 days you will be able to clearly gauge whether your mixed has worked or not. So don't be hurried. Why? Because you increase the dose of metformin, the insulin today, you check tomorrow, it's still high, you increase again, day after tomorrow, it's still high, you increase again, and then on the fourth or fifth day, your insulin dose is so high, the effect of the insulin will come in, and then you will put the patient into hypoglycemia. So you have to be patient in it. And next question is whether once you are the first patient where all the oral agents are not working and you're adding, and then you have added, you have decided that the patient will require insulin. Now, what will you do with the oral agents? Sometimes there are scenarios where patient has a very high control of uncontrolled sugar, and then you put on insulin and you stop all the oral agents. Now, if you're doing that way, it will mean that you will require a very high dose of insulin. So personally, what I do is, even if the patient requires insulin, I would still keep the oral agents and manage in such a way that the oral agents and insulin combined do not give hypoglycemia, but you still retain the oral agents so that the dose of insulin you are giving is reduced. Why? Because if you are giving 80, 100 units of insulin, the volume will be very high. And when the volume is high, when you inject, there are two issues. One is the local side effects like lipoatrophy, lipohypertrophy will be more. There will be more pain, and as you keep on injecting more insulin, the local skin will not be able to absorb, which means and then the other thing is, when you put that huge amount of volume into the skin, some of it will always come out, so which means it becomes very ineffective. So the higher dose of insulin given as injection will become very ineffective. The next point is the government gives only insulin in the syringe. And for those who can afford, who are afraid about the pain, you can advise them that they can get insulin pen. You will have to buy only the pen once and get your cartridges filled again. Now, if the patient can afford, better to go with insulin pen. Okay, so I hope I have made myself clear. Now, why do we really need oral agents and insulin, everything? Why do we need to take all the effort? Is because we want to prevent diabetes-related complications. Now, it can be small vessel, it can be retinopathy, nephropathy, neuropathy, or macrovascular and coronary artery syndrome, or ACS or stroke. Now, to really prevent these complications, if you ask questions, how do you really prevent complication? Is it only the control of diabetes? No. ADA says, see, lifestyle modification, diabetes education comes as a basis. Glycemic control is only one part of your solution. No, you should manage your blood pressure, you should manage your lipid and other agents. And then all these are required in combination. That is why in SCCI, we have introduced diabetes hypertension protocol together, which means these two protocols complement each other. Okay. That level of interpretation, in the protocol, when we are teaching the protocol to HA level, we keep it very simple. But for a doctor level, you really need to be comfortable in jumping from one protocol to another and mixing it and making combinations between the two protocols. So now almost coming to an end. One key area where we often forget, especially because diabetes is mostly managed by the medicine clinic, we always sometimes you forget to check the food. So food kinality you should always check at the pressure points where the areas of the foot where you will which takes a lot of pressure. So foot care food evaluation is important. The other part is that cleaning the foot, toe web, this will clean and make them dry, making them wear socks, making them wear shoes is very important. That because sometimes it is unfortunate, but we see patients who are moving around from one clinic to another, one OPD to another with wounds on the foot, and we have missed to check the sugar, or we have not, we are unable, where the sugar remains uncontrolled, and you're trying to heal the wound. So it does not serve the purpose. How to monitor for complications? Very easy. Heart kinalu, when you do ECG, you look for ECG LVH. And LVH criteria is voltage criteria. To check your kidney kinalu, you check the creatinine. And now wherever there is this EPs being rolled out, you can tell your lab that you click, the lab can put a click on while they are making issuing the final report, it will give you your EGFR calculated, okay? A CKD EPI formula, and you can check for urine proteinuria, IS fundoscopy.